if possible, we'll have some discussion. The last lecture for today's session is by Dr. HEMANTH Murthy. Dr. HEMANTH Murthy is my partner in Retina Institute of Karnataka. He did his graduation from Bangalore Medical College and post-graduation from All India Institute of Medical Sciences, and subsequently trained in retinal surgery there. And he's been part of Retina Institute of Karnataka for about 25 years. Well-known vitreoretinal surgeon and a speaker. He has won many awards, including the Reese Butler Award at the ASRS for his videos. And he's an authority on ultrasonography also. So I'm going to ask him to talk on how to use stains, PFCL, and other adjuncts in vitrectomy for RRD.
Thank you, Dr. Muralidhar. So I would be speaking to you on certain adjuncts that we use during retinal detachment surgery. Some of the things that you commonly use is triamcinolone to identify the vitreous, to induce the PVD, the ERM, and sometimes the residual vitreous as you proceed with vitrectomy. The brilliant blue that you stain to remove the ILM, and the use of PFCL, especially in GRT, traumatic RDs, PVRs. So this is a patient who came with a retinal detachment. Now, when we did the vitrectomy, it appeared as if I've been able to clear all the vitreous. But then when I stained with triamcinolone, you can see that the posterior hyaloid is still present. So you need to stain, put triamcinolone, try to identify whether there is residual vitreous. You would be surprised that in many of these cases, you see the entire vitreous being there. So it is a very good practice to use triamcinolone in all patients of retinal detachment to try to identify any of the residual vitreous. In this patient, you'd be surprised that most of the vitreous is present. This is another situation wherein you would like to use triamcinolone, and that is a patient with myopic macular hole detachment. This patient had a myopic macular hole detachment, and initially after I did the vitrectomy, I put in triamcinolone. Now what I'm peeling is not the ILM, actually it is the posterior hyaloid. So I first removed the posterior hyaloid around the macula. And when I stained with the triamcinolone again, I see that there is an entire amount of the vitreoschissis is very common in high myopia. So you need to put triamcinolone again and again, try to identify the vitreoschissis which is present in this situation. You would be able to achieve success only when you remove this. If you don't do this, there's a common failure of macular hole detachment in most of these high myopes. So you can, we can identify in all the quadrants the vitreous was present. So you need to put it again and again to really identify it. So this would be one situation wherein you do it, and in the end, you stain with brilliant blue and remove the ILM. So this patient did well. We had a closed hole, and I used gas in this because it does very well with gas, with less complications. Now, in a patient like this, again, after I've induced the PVD, I somehow feel that I would like to use triamcinolone because sometimes you miss the peripheral vitreous. So after I've done this, I put in the triamcinolone, and when I stabilize the posterior pole with PFCL, I can now peel the vitreous and remove the vitreous. So you can see that now you're able to identify the vitreous which is left behind. Suppose we have not identified it, this would get left behind and invariably cause problems for the patient. So using triamcinolone is a very good way to ensure that you're doing a good vitrectomy. Now I think in PVR we all know that we peel the ILM. So after I've removed the membrane, the ERM, then the best way to do it is to put in PFCL. Yeah, and remove the ILM, because under PFCL it tends to become a lot more stable. I stain under the PFCL, so actually you can go under the PFCL bubble and inject brilliant blue. It stains the ILM very well. And then try to peel the ILM from the disc to the periphery rather than the other way around. It is a lot easier to remove the ILM in this. So ILM peeling is probably done in most of the patients who have got PVR. Now, how do you inject PFCL? I see a lot of times, a lot of bubbles are induced. So this is a double bore cannula. So once you inject the first bubble, continue injecting into that bubble so that you end up with one single large bubble. This is a double bore cannula in a valved cannula patient. We are using valved cannulas. So you progressively increase the PFCL bubble. There are no additional small bubbles that are formed. So this will prevent it from migrating through large tears and causing subretinal PFCL. So this is a good way of injecting. You have to ensure that it is in a single bubble. And because it's in a valved cannula, there is no turbulence, so you don't get additional bubbles. Now, obviously, one situation wherein you definitely use PFCL is in a patient with PVR, because that gives you the third hand. So after we induce the PVD and remove the vitreous at the posterior pole, then we progressively stabilize the posterior pole first and continue peeling these membranes as we go peripherally. So this really supports the retina and allows you to do the peeling of all the membranes. And as you peel, you again fill up with PFCL and proceed to the periphery. So PFCL is indispensable in this situation. Another situation wherein you use PFCL extensively is a GRT. So this is a patient with GRT, and one good thing is that this patient also has rolled edges. So a good way to unroll these edges is to use the Finis loop. So in this patient, I use the Finis loop to unroll the edges under PFCL. Just to show you that, I think. So this is the Finis loop, and you can use that to unroll these edges. And PFCL provides you a good ability to stabilize the retina as you proceed. So earlier, when we are using non-valved cannulas, we could use the soft tip cannula because it had a longer tip. Now with the valved cannulas, the tips have become smaller, so they tend to be very traumatic. So this is a relatively easier and atraumatic way of flattening the retina using the Finis loop. So in this situation also, PFCL is very useful. Now, another situation wherein you find that PFCL is very useful is in patients who have had redetachments. And this patient had an ICL with cataract with silicone oil inside, operated elsewhere. And when I entered, I found that patient had the vitreous, posterior hyaloid was still present. I removed that. There was PFCL bubbles behind the retina, so removed it. And once I removed this PFCL droplets from behind the retina, then I could stabilize the retina by putting PFCL in front, and then continue the trimming of the edges and allowing the retina to settle. Patient had large tears in both nasal and temporal quadrants. So I ended up doing a bit of retinectomy, joining these two tears, and I could ensure a flat retina. So PFCL really is helpful in, whenever you do resurgery and to give you the stability to the retina. Another situation is traumatic retinal detachments, wherein you could use PFCL as a short-term tamponade. In this patient who came with a massive tear and detachment with subretinal hemorrhage. So initially, after clearing the hemorrhage, I put in PFCL, did bimanual dissection of all the membranes, both in front and behind the retina. And I did continue doing, I left the PFCL in this eye. So just to make it, yeah. So I did leave it for 2 weeks and then subsequently replaced it with silicone oil. So use of PFCL is now possible, especially in these bad traumatic eyes, to be able to keep the retina attached. And PFCL silicone oil exchange ensures that you don't get slippage in GRT. So these are very useful adjuncts when you do a retinal detachment surgery. So I would stress the basic greater use of it is into identifying the vitreous. I think triamcinolone helps a lot. You peel ILM predominantly in patients with PVR, myopic macular hole detachments. I don't do it routinely, so I only do when there is contraction that you would like to release. And PFCL is a very helpful tool, especially when you're managing PVRs, GRTs, and traumatic retinal detachments. Thank you.
Thank you, Hemant, for that wonderful lecture with very good videos. We have actually reached the end of our session. We can just have time for 1 or 2 questions from the audience, if any. If anybody wants to have any question, yes.
Hello. Yeah. I just wanted to know if the panelists have any opinion on fluid air exchange or followed by an oil, silicone oil insertion or directly fluid oil exchange. Are there any particular advantages or any indications for having?
In a GRT, that the question would be applicable predominantly in GRT. Otherwise, in most of the retinal detachments, we drain it, we do a fluid air exchange, correct?
Yeah.
So we wouldn't like to do. In a GRT, the only question is to avoid slippage, you would like to do it. But nowadays with wide angle, you can do fluid air exchange even in a DRT, provided you are patient. You have to allow adequate removal of the fluid that is there in the periphery before you start going down. So if you're careful, you can do fluid air exchange followed by silicone oil. But slippage you can avoid definitely if you do direct fluid PFCL silicone oil exchange. Okay. Because of physics. If you remember, the attraction of silicone oil to the surface of the PFCL does not leave any pocket of fluid like what happens with air. That's why that's a better option.
See, earlier we used to use a lot of PFCL oil exchange because we didn't have wide angle systems. So slippage will definitely happen if you are not able to visualize the edge of the GRT. There is always, whatever PFCL you use, some fluid will always be in the periphery.
Yes.
And once you start removing the PFCL, that fluid will dissect and go subretinally. If you are able to place the fluid needle there at the edge of the needle so that whatever the fluid seeps down anteriorly, that is removed first, then it's not going to slip, whether you do PFCL air exchange or PFCL oil exchange.
Thank you.
I hope your doubt got cleared.
Yeah.
It was what you were wanting about PFCL oil versus PFCL FAE oil. Yeah, okay. Thank you. I think we have...
Sir, can I ask a question just?
Yeah.
Yes. Sir, in case of buccal, like do you always do cryo followed by, or sometimes I have seen few people not doing cryo, just draining, putting a buccal, and in the post-op they are doing the laser. So I usually prefer doing...
I don't think that is advisable because post-operatively, in case something happens and you're not able to do the laser, then you're really stuck. So it is always preferable to combine cryotherapy, with your scleral buccal. I don't know whether
are you meaning to say that if the retina is very bullous and not able to do cryo, that is the question?
Sir,
then you can drain the fluid and then do the cryo also.
Yes, sir. Normally I just localize the break, do the cryo, put the buccal, but few people I have seen, they actually drain it, they put the buccal, put a gas bubble, and in the post-operatively they do the laser around the break.
Yeah, that is an option. It can be tried if provided you're using gas or air there.
See, one thing is that you don't have to really oppose the retina and the RP. If it's a bullous also, if you are at the right place, if you give a sort of reaction at the RP level and the retina attaches, that reaction itself will be enough. But if it's very bullous, you're not able to do, definitely you can put a buccal drain and you can do later on also. So the retina is not going to lift up.
See, basically what Dr. Kumar said, I agree. Previously, there used to be, and there are few paper also, because you don't want to do cryo, because you don't want excessive reaction, you put the buccal, flatten retina. If you can drain and flatten on the table, you do a laser as well. Or you can do next day. Or sometime before even putting buccal, you can, when a shallow detachment, if there is a depression, you can depress and oppose the retina, you can still do the laser. That used to be option, but what happened, end of the day, and when you close the case, you want to ensure all the steps done in a satisfactory way. You don't want to leave the things for chance. It's just sometime happen, you settle everything, you said, okay, I'll do laser tomorrow, and next day you see now there is fluid. Now you cannot get the reaction, and now because buccal is there, you cannot do cryo also. So yes, it can be done, but you don't want to leave things for a chance. So better finish everything on the table at the same time.
Thank you.